My name is Stefan Anke, and we're here to discuss some hearty issues regarding NAFLD and NASH and the cardiovascular perspective. With me is really distinguished faculty, and I know that we have an interdisciplinary, very well-educated, I'm sure, audience, and I'm looking forward for having good discussions then also for the presentations. For the discussions to come across with the questions, please put them into the Q&A section in the bottom of the screen. We have another 85 minutes of great discussion ahead of us. Maarten Tushuizen from Leiden University. What is NAFLD and NASH? Please, Maarten, over to you.
Thank you very much, Stefan, for the nice introduction. I would like to talk to you about the definition of NAFLD and the preparation of NAFLD NASH and some background of NAFLD NASH. These are my disclosures. So what are NAFLD and NASH? NAFLD is defined by the presence of lipid accumulation or steatosis in more than 5% of the hepatocytes, according to histological analysis or by imaging, like MRI. NAFLD encompasses a continuum progressing from simple steatosis to non-alcoholic steatohepatitis or NASH to fibrosis and finally cirrhosis. And we speak of NAFLD when only steatosis is present and there's no evidence of hepatocellular injury, as depicted on the left histological sample here. So you see the hepatocytes and you see only the steatosis. In contrast, we speak of non-alcoholic steatohepatitis or NASH when in addition to the steatosis, there's inflammation and damaged hepatocytes, or the damaged hepatocyte will become ballooned and you see some fibrosis, but it's not necessary for the diagnosis, as you can see depicted on the right figure. So what is important is that the diagnosis of NAFLD requires the exclusion of especially daily alcohol consumption. For men is that less than 30 grams of alcohol, or on average less than 21 standard drinks a week, and for women less than 20 grams of alcohol a day, or less than 14 standard drinks on average per week. So alcohol consumption above these limits indicates alcoholic liver disease, but patients consuming moderate amounts of alcohol may be still predisposed to NAFLD if they have the metabolic risk factors. Moreover, there are some other conditions that may lead to hepatic steatosis, including chronic hepatitis C virus infection, parenteral feeding, and some drugs like methotrexate and valproic acid. So these are the secondary causes of steatosis and should be ruled out before you could say that a patient has NAFLD. So this brings me to the next discussion, because while NAFLD is very familiar among hepatologists, it defines the condition by what it's not. So it's non-alcoholic and does not highlight, for example, the insulin resistance and the metabolic disorders as the major underlying cause of fatty liver development. So consequently, metabolic associated fatty liver disease, or MAFLD, has been suggested by some experts as an alternative name. However, there is not yet universal support for this proposal, and one of the reasons is that the disease also occurs and progresses in some people who do not have metabolic disorders. So this discussion will continue the upcoming years, I think. How prevalent are NAFLD and NASH? Well, it's estimated that 25% of the global adult population is potentially affected by NAFLD, with the highest prevalence in the Middle East, as you can see on this slide, and South America, and the lowest in Africa. So around 20% of NAFLD patients have NASH, of which 1/4 have cirrhosis. So the problem with these figures and numbers is that the prevalence is rising. If we model the epidemic of NAFLD, it demonstrates exponential increase in burden of disease. And it is expected to increase in parallel with the epidemics of obesity and diabetes. And so this also have several other effects. So mortality and advanced liver disease are expected to be more than double between 2016 and 2030, as these figures show. And the forecast that prevalent NAFLD cases in the USA would increase 21% from 83 million in 2015 to over 100 million in 2030. And while the prevalent NASH causes would increase 63% from over 60 million to almost 30 million cases. So overall NAFLD prevalence among the adult population is projected at over 33% in 2030. And the proportion of NAFLD cases having progressed to NASH is projected to increase to 27%. So these are huge numbers of patients. Well, this is only the data from adults, but the prevalence in children is also very astonishing, actually. In 2015, a meta-analysis calculated the pool prevalence of NAFLD around 8% from general population studies, but it's rising to 35% in studies from pediatric obesity clinics. And the prevalence was especially higher in young males compared with females, and increased, of course, with greater BMI. So the other thing is that NAFLD also occurs in children and adolescents with normal weight. So this is also an issue for the future. Well, as I stated before, the rise of NAFLD prevalence has everything to do with the increasing rates of obesity and insulin resistance. And it may therefore not be surprising that NAFLD is regularly described as the hepatic manifestation of so-called metabolic syndrome, a cluster of cardiovascular risk factors, and that include central obesity, increased plasma glucose, triglyceride concentrations, and decreased HDL concentrations. Increased blood pressure and central obesity is central in this syndrome. The metabolic syndrome is therefore a very common condition in patients with NAFLD, with a prevalence of over 50% in patients, especially the patients with NASH and significant fibrosis. So also the development of type 2 diabetes is important. The NAFLD prevalence in these patients is extremely high. And with the increase of obesity the upcoming years with the so-called Western lifestyle, also the metabolic syndrome and therefore NAFLD will increase as well. So this slide, this figure, shows you the association between NASH, type 2 diabetes, and hypertension, especially in obese patients. As I said, obesity is an independent risk factor for NAFLD, and over 80% of the patients with NASH have obesity. And the obesity, including with the lipotoxicity, results in the accumulation of lipid metabolites that will result in inflammatory pathways, cellular dysfunction, and apoptosis, and that will lead to multi-organ failure, including type 2 diabetes and cardiovascular disease. This figure shows you the association between type 2 diabetes and hypertension in patients with NASH. And if a patient neither has one of these conditions, the prevalence of NASH is only 7%. But if you have both type 2 diabetes and hypertension, the prevalence of NASH is 75%. So it's enormous. So how can you show the relationship between NAFLD, type 2 diabetes, and the metabolic syndrome and all these other features? This figure shows you schematically the relationships. NAFLD is associated with features of the metabolic syndrome, such as central obesity, cardiovascular disease, hyperglycemia, and NAFLD increases the risk of type 2 diabetes and chronic kidney disease and cardiovascular disease. And with the development of type 2 diabetes, there's a further increase in risk of cardiovascular disease and worsening of liver disease. So the formation of fibrosis and eventually cirrhosis, and therefore an increased risk of hepatocellular carcinoma and other extrahepatic cancers. So the development of advanced liver fibrosis also doubles the risk of cardiovascular disease, but my colleagues will elaborate on this later. I will demonstrate the prevalence of NAFLD and fibrosis in type 2 diabetes, because this is very important. For instance, in the Netherlands, we have over 1.2 million patients with type 2 diabetes. And yeah, the problem is there's not much attention for NAFLD, but it should be, because this meta-analysis of over 50,000, approximately 50,000 individuals with type 2 diabetes showed that the prevalence of advanced fibrosis and NAFLD in the regions of the world. And their main finding was that the prevalence of NAFLD in patients with type 2 diabetes is more than twice as high as in the general population. So the overall prevalence of NAFLD amongst patients is over 55%, with the highest prevalence in Europe, 68%, as you can see. The global prevalence of NASH among these patients with type 2 diabetes is 37%. And of the patients with NAFLD and type 2 diabetes who undergo a liver biopsy, 17% of those patients had advanced fibrosis. So this is really serious. Not only have individuals with type 2 diabetes a greater risk of developing NAFLD, follow-up studies have shown that NAFLD is also associated with an increased risk of incident diabetes. A meta-analysis performed by Montovani showed that the magnitude of the association between NAFLD and risk and incident diabetes is very high. You see a hazard ratio of 2.22. So patients with NAFLD have an increased risk of developing diabetes, and the diabetes itself will worsening the NAFLD, the formation of fibrosis, and so forth and so forth. So this is also a real problem for the future. This slide shows you also the prevalence of steatosis and fibrosis in patients. This is in over 561 patients with type 2 diabetes. They were attending the endocrinology outward patient and or the primary care, and they were unaware of having NAFLD. And so patients were screened by elastography for steatosis and fibrosis. And the prevalence of steatosis in these patients was 70% and fibrosis 21%. So moderate fibrosis was present in 6% and severe fibrosis in almost 10%. So there are a lot of patients with type 2 diabetes unaware of these high risks. So we need to form regular care paths to detect these patients. But this is something in progress. I would like to highlight this increased risk of cardiovascular disease. Again, my colleagues will elaborate on this later on, colleagues Holleboom and Franke. But I would like to emphasize that this meta-analysis by Targer almost 6 years ago showed in a retrospective studies of 34,000 individuals that patients with NAFLD had a high risk of fatal and non-fatal cardiovascular disease events than those without NAFLD. And the summary hazard ratio was 1.64. So also very, especially for the cardiologists among us, this is also a very important finding. So there are also other diseases or symptoms that are important in patients with NAFLD, especially the chronic kidney disease. This meta-analysis of over 1.2 million individuals show that there's a significantly associated risk of developing chronic kidney disease in patients with NAFLD of 1.45-fold. And all these risks are independent of age, sex, obesity, hypertension, diabetes, and other conventional chronic kidney disease risk factors. Moreover, very recently, a meta-analysis of large cohort studies of almost 200,000 patients showed that patients with NAFLD also have a significantly higher risk of developing GI cancers like esophagus cancer, stomach cancer, pancreas, and colorectal cancers, 1.5-fold to 2-fold. Moreover, also lung, breast, urinary tract system cancers are increased in those patients. So if we picture the previous slides in this figure, then we see that NAFLD is a continuum. Around 25% of the global adult population is estimated to have NAFLD, related to the unhealthy lifestyles, especially the so-called Western diet, which drives the obesity and type 2 diabetes. In the United States, approximately 25% of NAFLD patients have NASH. Of these, it is estimated that around 1/4 will develop advanced fibrosis and cirrhosis. So previously, a systematic review and meta-analysis showed that the rates of fibrosis progression in patients with NAFLD is approximately 14 years. So in 14 years, patients with just simple NAFLD will develop 1 grade of fibrosis. But patients with NASH, with the inflammatory compound, this will only take 7 years. And why is this important? It's important because liver fibrosis has been shown to be the most important predictor of mortality in NAFLD. Here you could see a meta-analysis of a large amount of patients, of almost 1,500 patients with more than 70,000 patient years of follow-up. And you see the increased risk of liver-related mortality. It exponentially increases with the increase of fibrosis stage. And another review and meta-analysis by Taylor of over 4,000 patients showed that fibrosis stage was associated with all-cause mortality, liver-related mortality, and morbidity. So it's also important for us to detect the liver fibrosis stage in patients with NAFLD NASH. Okay, this again also has effects on the estimated patients with NAFLD in the future. You can see the projected number of NAFLD with compensated cirrhosis and end-stage liver disease, and it will increase in every country by 2030. Especially in France, you see a large increase of over 150%. So this is also has very effect on the incidence of hepatocellular carcinoma, especially in the upcoming years, and also in the patients with non-cirrhotic patients, because nowadays we are very usual to screen patients with cirrhosis, but it is estimated that especially the patients with advanced fibrosis but not cirrhosis will develop hepatocellular carcinoma in the near future. So therefore, it will not be surprising that NASH and NAFLD will also be the most rapidly growing indication for liver transplantation. So I will come to my final slide. NAFLD NASH, it's increasing, common worldwide, and the primary cause of chronic liver disease. NASH is characterized by hepatic steatosis in combination with inflammation and balloon hepatocytes, with or without the presence of fibrosis. And NAFLD is closely related to the metabolic syndrome, type 2 diabetes, and cardiovascular disease, and is a multisystem disease. Fibrosis is the most important predictor of mortality in NAFLD. So for the future, the near future of NAFLD, we should have more awareness of NAFLD and NASH in the general population, in the politic, in primary care, in second-line colleagues. We should develop tailor-made non-invasive parameters and biomarkers to specifically identify the patients at risk, for example, fibrosis or cardiovascular disease. And we should develop survival intervals for fibrosis, for hepatocellular carcinoma, and for cardiovascular disease in specific patient groups. And therefore, we need collaboration and multidisciplinary care path. So we need the endocrinologist, we need the hepatologist, and we need the general physician and the diabetic nurses, for example. So thank you for your attention.
Thank you so much, really, for this excellent overview and setting the stage for what is to come about the discussion of the interaction with the heart and the actual management, of course. But I would like to highlight together with you the one point that you already made so clearly, that fibrosis is at the heart of all this, and the very impressive relationship you showed between all-cause mortality observed and the severity of the fibrosis being assessed. How is this mechanistically coming about, the fibrosis?
It's a really good question. I do think that my colleagues will elaborate on that, because we know that, for example, there is a relation with left ventricular stiffness and the amount of fibrosis in the liver. So you could also say that the damage that occurred in the liver and caused the formation of fibrosis also will damage the endothelium, for example, and that causes the atherogenesis and the development of cardiovascular disease. So if you look in, for example, the atheroma, the same mechanisms that development of atherogenesis play a role in damaging the liver. So the cytokines, the lipids, the glucose, and all those factors have the same kind of damage.
And so it's a global inflammation process, and basically nature somehow getting it wrong in the attempt.
Yeah, it's also very intriguing why because sometimes you have a patient with a BMI of 50 and type 2 diabetes and hypertension, but then he doesn't develop NASH and he doesn't develop fibrosis. So why is that the other patient with the same characteristics does develop NASH and does develop fibrosis? We don't know yet, but we should be aware that these patients are there, especially the patients with type 2 diabetes, and we should identify those patients on time. So therefore we can change their therapy, or be more aggressive in surveillance, or be more aggressive with lifestyle changes. So this is something for the future.
I mean, you highlighted also the very big importance of diabetes and the association that all these metabolic problems are particularly present in diabetic patients than for the liver. What if you take the global NASH, NAFLD population, what is the proportion of diabetics? I don't know, 3/4 versus the proportion of non-diabetics. Is it happening in non-diabetic patients at all?
It is, but the patients at high risk for developing NASH are the patients with type 2 diabetes, and also those with the comorbidities. So with the chronic kidney disease, with the cardiovascular disease, with the heart failure.
Mm-hmm. So would you then finally say, if screening is in the future so important for this, because really we need to find these patients, what are for the physician going away tomorrow to the practice, to the hospital, what's the 1 or 2 or 3 tests that can easily be done?
Yeah, so I would
screen.
surely advocate for screening. As we screen for retinopathy, we screen for neuropathy, we screen for diabetic nephropathy. So we should screen for the diabetic hepatopathy. And because fibrosis is important, easiest test, for example, is FIB4. The only problem is that FIB4, that's a test combination of transaminase, thrombocytes, and H. The only disadvantage of FIB4, it's not that really precise in patients with type 2 diabetes.
Can you say a little more? I mean, okay, transaminases, I think everybody knows, but this, I'm sorry, I've never heard this abbreviation FIB4 before. But of course, I'm a naive cardiologist.
Now, FIB4 is developed for screening patients with liver disease on the risk of having fibrosis. So there are cutoff values. If you have and it was tested by Srivastava in London in the general physician practitioner, that if you had a FIB4, so AST, ALT divided by thrombocytes and H, if you have an outcome of less than 1.35, then the chance of having advanced fibrosis is nearly nil. But if you have above this cutoff, then there is a chance of having advanced fibrosis. So it can be used in the general population. However, again, in especially type 2 diabetes, it underestimates. So only the use of transaminase will also underestimate the amount of liver damage. So you can have a normal liver enzymes, an AST of 35 with an ALT of 40, and still have advanced fibrosis. So we cannot rely on liver enzymes alone. So we need combinations. We need, for example, also to test if ELF test, that's a combination of 3 proteins that are important in the development of fibrosis, can be used in, for example, the general, in the first line in primary care, or maybe also can be used in annual, or maybe once a 3-year or once a 5-year screening for type 2 diabetes. But that are all programs that we need to develop now, and we are together with Onno Holleboom, for example, who will be the next speaker. We are currently developing those type of programs in the Netherlands.
Okay, Maarten, we have 2 more questions here in the chat. You indicated that lipotoxicity is contributing to the vicious cycle. What is your opinion on controlling lipogenesis for NAFLD?
Yeah, I do think that that Sven Franke will elaborate on that. But if you take, for example, take statins, some of us are a little bit reluctant in prescribing statins in patients with elevated liver enzymes or the risk of having a damaged liver. But studies demonstrate that it's safe and also may even have a beneficial effect on fibrosis. So I don't think we should be reluctant prescribing statins, for example.
And maybe Michael Bettel is asking two questions. Should patients who are both diabetic and obese be assessed as quickly as possible? I guess you might very much advocate for this. But there's also an AI-driven diagnostic test with 10 biomarkers called LiverFast. Can you comment on how that might be used in screening?
No, I'm afraid not. No.
I mean, then I ask a simpler version, and this is also to Onno and to Sven. This I don't want to mispronounce it. This Azad-Allah thrombocyte H ratio kind of test.
Yeah.
Is this coming automatically in your tests? I have never seen this. I'm sorry.
Yes, in our hospital.
I have to do that. Yeah.
All right. Is this a special liver kind of thing you have to go through, or is this in the endocrinology? In cardiology, I've never seen this. Maybe I don't know. Maybe in our place we are behind the woods, so as to say, but I don't know.
Yeah, I do think we should have it but again, in diabetic patients, it gives an underestimation of the presence of fibrosis. So I'm not convinced that FIB4 will be the future of screening high risk patients, especially type 2 diabetic patients. But we will come up the upcoming, let's say, 2 years with a very nice.
Okay. I think we have to move on, if you all agree.